Good morning, everyone. We will get started in just a minute or two. Thank you.
The screen is not shared.
There it is, but I can't get the. All right, can you hear me?
Yes.
Can people? Okay. All right. Well, let's get started. Sorry about the confusion at the beginning. This is new technology. It's the first time we've used this version of Teams. So, welcome to the Medicaid Advisory Committee. My name is Mitch Robe. I serve as the Secretary of FSSA and as the Interim Medicaid Director. If I can get my MAC members should type their names into the comments of the meeting so their attendance can be recorded. So please go ahead and do that. Here's the agenda today. We'll move through it with all deliberate speed. So we have a call to order. And please state your name and organization. Let's see here. I'm going to start with Lindsay Lux.
Hi, Lindsay Lux. I'm the Deputy Director and Chief of Staff for Medicaid.
Liza.
Liza stepped away to take a phone call.
All right. Liza Sherman is the Policy Director and Legislative Director for FSSA. All right. Okay, are there actually 114 people on this call? Apparently.
There are FSSA employees who have joined the call to listen.
Okay. All right. So we have, I'll just start with Amanda DeRoss. Amanda, do you want to?
Yeah, Amanda DeRoss, Deputy General Counsel for FSSA.
Donna?
Donna Elbrecht, CEO of Easter Seals, Northeast Indiana.
Kat?
Kat Etter, Director of Clinical Operations for OMPP.
Ashley? Ashley Hall. Kim Dotson?
Kim Dotson with the Arc of Indiana.
Charity Lumpkin?
Member Experience Manager with the Office of Medicaid.
Kate Marshall is on. She manages my schedule and what I do. Neil Salmon.
Good morning, Neil Samahan, CEO of Opportunity Enterprises.
Sarah Saylor.
Good morning, Sarah Saylors, Director for Division of Mental Health and Addiction.
Terry Cole,
Good morning, Terry Cole, Indiana Hospital Association.
Lindsay Weaver,
Lindsay Weaver, Commissioner, Department of Health.
Namerita Yancey,
Hi, Namrita Yancey, Operations Manager of OMPB.
okay, there are 96 people watching here. I don't, let's see that's all the people that are coming up on my screen. So, I'm just gonna move on then, because candidly, I can't figure out how to get 97 people to announce their presence here. So, if you ask a question during the question period, please state your name and organization. Okay, please review the MAC handbook, which was sent to you this morning. It outlines membership logistics and the code of conduct. All MAC members are subject to the State of Indiana and Office of the Inspector General Code of Ethics. Please complete your training. There's a link here to your training. Please report your completion by sending your completion certificate to mac@fssa.in.gov. So let's go with the Medicaid financial update. I thought about, so many people have seen this slide. It evokes a variety of responses. One of which is it's the Titanic and going to hit an iceberg. Which if we don't reform our finances, we will be. Secondly, we're all in this together on the FSSA. We provide services to 2 million Hoosiers, all of whom are less fortunate than most who are on the phone today.
Secretary,
Yes.
I apologize for interrupting. We've been asked if we can pause for just a couple of minutes to allow a couple of members to get on the presentation.
Always. Okay.
So give me just a second. Okay, Secretary, Representative Clear has joined the meeting. So if you could please start at this first slide again, that would be great. Thank you.
Okay, so many people make an allusion to this and comment on this slide about what this means. And it could be the Titanic headed for an iceberg, and it will be if we don't get our finances in order. It could signify that we're all in this together, and FSSA is an organization that provides services to over 2 million people a year, almost all of whom are far worse off than those of us who are fortunate enough to be on this call today. It also could signify that FSSA is a big ship and that it takes a long time to turn a big ship, but the best time to start turning that is today. And in some respects, it means all those things. So I'm going to take you through just a bit of an overview that isn't really just about Medicaid. We all know that the SNAP benefit was delayed. They're supposed to go out tomorrow. The Trump administration has indicated They will partially fund the SNAP benefit. We are hopeful those dollars go out quickly. We just this morning at 8:30 we received instructions from FNS in terms of how to operate that, and we will get those out as soon as we possibly can. But really, it has more to do with FNS loading the dollars onto the SNAP benefit card. None of our other divisions have been significantly affected negatively by the shutdown, with the exception of approvals due to lack of staffing at FSSA. But this has not caused a significant impairment for us. So I'm going to take you through some of the stuff you may have seen before, and to set the stage for a conversation about where we need to go with the Medicaid program. So you could largely break the program into three major areas. One is the Healthy Indiana Plan, which serves able-bodied adults. The second is Hoosier Care Connect and Hoosier HealthWise, that largely serves pregnant women and children. And then there's fee-for-service and pathways. And if you look at the per member per month and the amount of participants, you'll notice that the per member per month has increased in HIP over a decade, but not really that much, right? By $200. Similarly, a $100 increase for Hoosier HealthWise and Hoosier Care Connect, but an enormous jump in fee-for-service and pathways. And unfortunately, that is likely to be where we will need to squeeze most of our savings from. There's very little savings to be had in dealing with the hospitalization of pregnant women and children. They just don't cost very much. So not that we won't be trying in every area of the agency, but I mean, I want to be clear to people that it is the fee-for-service and pathways portion of the agency which we will be focused on for cost growth trajectory mitigation. So why is this so important? Well, the Medicaid appropriations over the course of the last 10 years has grown dramatically. In 2017, it was about $2.1 billion. Today, it's about $5 billion. That is 134% growth over that period of time, or 9.5% annualized compounded annual growth rate. That is significantly faster than the General Revenue Fund. I was with former State Senator Teresa Lubbers, who told me that when she joined the legislature, I believe 1992, the Medicaid budget was smaller than the budget for higher ed. So that was some time ago, but nevertheless, and that's what happens over time. We are slowly eating the rest of the state budget, and we can't continue to do that. How did we get there? Well, a variety of different ways. One is the growth of ABA therapy. Enormous growth in ABA therapy from 21 million in 2017 to 611 million in 2023. This year, that number will be back to about $600 million again. So that's an enormous growth rate. Another place is attendant care, the acceleration of attendant care. In March of 2021, we were spending about $15 million a month. By March of 2024, we were spending $85 million a month. And on this slide, I'll reference you to the enormous growth in people receiving care over 60 hours a week. I mean, I think we need to have a serious conversation about how much care we can afford to provide to individuals who are receiving home and community-based services, as opposed to congregate settings, in terms of how much we're spending on those care models. Another place that we've seen enormous growth is federally qualified health centers. So the red line that you see is what we pay a provider of healthcare services for a primary care visit in, say, Fishers, Indiana. It's $99 a visit. Yet there are federally qualified health centers whose PPS rates exceed $600 a visit. Yet, and there are others where the PPS rate is at $200. That inequity baffles me. And so we've got to get this under control. But again, recognizing the problem is the first step in solving it. Very few of our programs have any quality metrics. And as Milton Friedman says, one of the greatest mistakes is to judge policies and programs by their intentions rather than their results. So let me talk a little bit about some of the results. HIP 3.0, I think we all are aware that Indiana needs a hip replacement. That's my wife's line. She makes me indicate that was her clever line earlier in the year. We know we're going to have work requirements. Those will be effective 1/1/27. We tried to move them up. The CMS told us that they would not be ready to be moved up. So we have delayed them till their effective date of 1/1/27. We'll have a revised benefit package design, hopefully one that incentivizes wellness. The current lawsuit that we're in, which is referred to as the Rose decision, really ended the healthy part of the Healthy Indiana plan. And so we hope to be able to restart that. We've got several ideas, and as soon as we're done submitting the rural health package, we'll begin more public dialogue on what HIP 3.0 looks like. Which brings me to rural health. Today we are submitting our rural health application. Many of you, I hope, have been participants in that conversation over the course of the last couple of months. It has been a bit more, the federal government put a very quick timeline on this. So we were able to work collaboratively with our colleagues at the Department of Health, and a shout out to Dr. Weaver and her team to pull this together in record time and get it delivered. Let's talk a little bit about Indiana's healthcare challenges. We have high hospital prices. When I was here 20 years ago, people talked to me about the high hospital prices, and I would say, well, we have high hospital prices because we have a very high uninsured rate. So we did HIP 1.0, we did HIP 2.0, we did equalization with Medicare, and we still have high hospital prices and substandard health outcomes. So we are extremely disappointed by that. We have told the hospitals that we believe that they have broken a covenant that they have made with the General Assembly and 3 governors, and we are determined to incentivize hospital cost reductions, leveraging Medicaid reimbursement as a strategic tool in implementing a direct payment to incentivize hospitals to lower their costs. So to say this is not contentious would be a misrepresentation. But we continue to be anxious to work with the Hospital Association and other large hospital systems to create both near-term and long-term plans to lower our commercial rates. To be candid with you, we have a healthcare delivery system we cannot afford, right? I showed you those charts where we're growing at 9%, 9.5% a year. That is significantly faster than everybody else. This is the NFP ACR study. That's 265. This is the price that we're paying here in commercial rates above what is generally perceived to be the national average. So as I referenced many times before, the governor and I are on our last buffalo hunt. We have one more chance to get dollars out of the federal government, and then they will take the Indiana Medicaid program, they will put it in a box, and they will lock it and put it in the freezer, and we will need to live within our means. So we are determined at FSSA to figure out ways to minimize our trajectory, particularly in general revenue fund Medicaid assistance appropriation. As most of you know, that we did the Healthy Indiana plan spent $6.3 billion, and we figured that out by adding up the number of people who were on the program times the per member per month times 12, and that number turned out to be 6.3 billion. And we did the same thing for Hoosier Healthwise, Hoosier Care Connect, et cetera. And in total, that added up to $17.8 billion, or close to 17.9. We then went and said, okay, how many federal dollars do we get? Okay, that's how many we get. $13.4 billion. How many provider taxes? How about the half funding? How about the HIF funding? What about the IGTs? And that adds up to $15.2 billion. Well, $15.2 billion is less than $17.8 billion. So we walk over to the State House and tell the Budget Committee and the governor's office that we need $2.9 billion to balance the Indiana Medicaid program. And by the way, that was a 26.9% increase over the previous year's general fund Medicaid assistance appropriation. And we did the same thing the following year, and that was a 12.8% increase. And then the same thing the following year, a 9.5% increase, and then a 7.7% increase. And that's how you grow a program 134% over the course of a decade. So we are determined to figure out how to manage that cost growth trajectory to something that approaches what the general fund revenue growth trajectory is, of about 2%. And so you'll see us over the course of the next several months and years rolling out different programs, working with providers to create different care models that we can actually afford. So with that, I think I'm done. Let me pause here, if I may, and say I'm happy to have people introduce themselves, but I just think with 90 people, it's going to be a free-for-all. So I'll start with if you're a member of the committee, please introduce yourself. And I'm going to start with Ed and other members of the General Assembly who are on the phone today. So I don't really have visibility into who's on. So I'll just let Ed, Representative Claire, begin.
Mr. Secretary, I know Representative Claire was having some audio issues. So I think he might be trying to work on those.
Okay, well, who's the, do we have other members of the General Assembly on the phone?
This is Representative Shackelford. I have a question.
Well, let's do introductions first, if I may. Apparently, I frustrated people by not figuring out how to do introductions, and I did not, that was unintentional on my part. So, but you'll get the first question.
Okay, so even though we put our names in the chat, you just want us to come in and introduce ourselves?
If you don't feel that's necessary, I'm happy not to.
I don't feel that's necessary. I think everybody put their name in the chat if they're on here. I think you might want to go ahead and proceed with questions.
Okay, I will. Go ahead. So you're up first.
Well, my first question is, when are we going to go back to meeting in person?
Yeah, that's a good question. I don't know that answer. I much prefer an in-person meeting. I think we tried to do we tried to do an in-person hybrid meeting, and for some reason, we had new technology and that we were afraid that wouldn't work. But I would say the next meeting will be in person. I mean, barring some unforeseen circumstance, we'll do the next meeting in person, and we'll try to do it virtually and in person. We managed to do that pretty effectively if you logged into the rural health program with both in person and virtual, and that worked pretty well. So I don't know why so we'll change that.
Okay, that'll be great. My next question is for the SNAP, since partial funding is coming from the federal government, does that mean that our recipients are going to get like a certain percentage of their normal allotment?
That's a good question. Again, that would be I would infer that from what I've heard, but I've not read we just got the ruling literally as we were getting on this call. So I don't know that answer. I anticipate that will be the case. We will put out a statement if it's not that. I don't know how else they do it, candidly.
Okay, and then my last question, just to refresh my memory on how we're going to use the Medicaid bucket as an incentive for hospitals. Can you let me know what that looks like?
Sure. We have created different classes of hospitals. So smaller rural hospitals will receive up to 150% of their Medicaid and Medicare reimbursement in Medicare rather than Medicaid. Medium-sized hospitals can earn up to 140% if they have costs significantly below 265% of what's called the average commercial rate. And large hospitals, if they're over the large hospital systems, if they're over 265%, would see their reimbursement go to 75% of the Medicare reimbursement rate.
Okay, and then large hospitals, if they're under the 265, what would they get?
They can earn up to 108% of Medicare.
Medicare. Okay. All right.
Medicare and Medicaid, for the sake of this conversation, we talk about them being parity. They're not, that's not completely true, by the way, but it's close.
Okay. All right. Thank you.
Secretary, this is Fadi. Can you hear me?
One more, can you reintroduce yourself?
This is State Senator Fadi Kaddoura. Can you hear me?
Okay. Yes. Yes, Senator.
Great. Well, thank you for the presentation. I want to reiterate the question that I've shared before, and I don't think I'm getting answer to. Your entire strategy is focused on getting the fiscal under control for the Medicaid program for 2 million people. And you referenced the discussion you had with a former state senator and commissioner of higher ed about the 1990s. So looking over the last 30 years, it seems it's one of two things. We are either a state that cannot take care of the most vulnerable, and we are a poor health state, and the numbers will continue to increase, or we are a state that can afford to do it. However, we are only looking at the finances every 4 years when a new secretary of FSSA joins, and when they leave, we are back at the same exact point of discussion. I've shared with you my concern that no one is really critically looking at strategically at how do we improve the health, because if you control the fiscal, you are not controlling the health of the state, and people will get more sick. And in 5 years, the Medicaid budget is going to go $5 to $10 billion more. So it is not wise to keep shrinking these programs and services just for a short-term benefit, just to control the budget for 2 more years, and then blow it up in 5 years because we will be surprised that we've never took care of the health. So who in the agency is working on the strategic objective of improving health so that we can actually reduce Medicaid spending by making people healthier? I'm perplexed by the strategy of just cut, cut, cut. And I don't hear any discussion on the
Yeah.
strategy to make people healthy.
Well, in the first place, I would say that uh, the federal government does not believe, apparently not the particularly the previous administration and the courts seem not to believe that the Medicaid program is about trying to make people healthier. They seem to believe that it's about paying claims, which is disappointing for us. And my evidence of that would be the previous administration's December executive order indicating that work requirements and other modifications of the HIP plan and other programs were not legal, and the court's reiteration of that in the Rose decision. So that's the first issue, which is I think we need to have a discussion about what is the purpose of Medicaid. So in 2000, I'll try to answer your question not with in less than 20 minutes. Our first goal has to be, unfortunately, to get the Medicaid funding under control and to create a care model that we can afford. And in the process of doing that, we are hopeful that there will be mechanisms by which we can help Hoosiers to improve the status, their own health status. And that will be stuff that we're focused on in programs that we're focused on in 27 and in 28. We hope that will be part of our budgetary program. The other piece that you referenced here is the forecast. I just left this forecast up. There is currently no forecast for 28 and 29, right? It's not as if the Indiana Medicaid program is going to go away, right? We will be there. So we need to create longer term forecasts, and we need actuarially to determine what wellness programs will be cost effective and what wellness programs will not be. So I want desperately, Senator, to believe that prevention and wellness works not only for the individual, but for aggregate cost savings within a targeted population. I desperately want to believe that's true because I've invested a tremendous amount of my time and of the taxpayers' money in that proposition. I've not seen data that makes me believe that that proposition is beneficial to the aggregate. I think prevention is definitely beneficial to the individual in terms of decreasing the pain and suffering that they face. But in the aggregate, it's more difficult to tell.
Well, I appreciate your answer. I'm not going to dominate the discussion because I'm sure others have other questions. But if we are on a hunt for the last buffalo, and I know that it's not your fault or the governor's fault, but the previous administration spent 2.5 billion with a B only on 2 projects on the LEAP and in Westville Jail or prison in Northwest Indiana. We have $46 billion biennium budget. So the question to me is not whether we can't afford Medicaid. It is more about priorities. That's the first point. And the final point, I would urge you to look into if we are that desperate and we don't have enough money and we're cutting rates and for providers and units of service to patients and to individuals, I would urge you to look at the managed care entities contracts that FSSA have and help us understand what is the profit margin for-profit insurance companies that benefit annually on serving 2 million people in Indiana. And similar to the PBM discussions, the General Assembly was interested in bringing back and insourcing the PBM to save dollars and manage the program. If we're getting into crisis mode and we're truly looking for dollars, then I would urge you to look into the feasibility of what does it mean to insource the Medicaid program.
So let me comment on a couple of those things, if I may. The first, let me just go off the PBM piece. I think over the course of the next couple of, certainly the next, by January, we'll lay out a PBM strategy that will approach PBMs differently for Medicaid than we're currently approaching, that will likely approach Medicaid PBMs and Medicaid differently than we are currently approaching them. And so we'll be rolling that out when you guys are back here hopefully in early January. The other piece that you raised is the medical, what I'll call the Medicaid loss ratio, the medical loss ratio. There's a perspective in contracting with managed care entities called the Medicaid loss ratio, or the medical loss ratio, where 85% of the spending needs to be, quote, below the line, close quote, and 15% needs to be above the line. Now, that's not their profit margin. That's their administrative cost and profit margin. So we would, I have, and I think I've told you this before. I forget what you've been forced to listen to and what you haven't been. But 20 years ago, I tried to get the healthcare industry, the hospitals, to take direct risk on what was then a much smaller Medicaid managed care population. And I spent a long time creating an RFP, putting it out, and I got no responses back. So I was very frustrated with that. We would be, and we have told the hospital industry that we would be open to doing that again if they were willing to do the lifting in terms of how we might structure that for them. So they've indicated a interest, and I wait for their response.
I appreciate your responses. I'll yield the time to anybody else, and I look forward to continuing the discussion with you. Thank you.
Other questions? Okay. On with the rest of the meeting. Okay, Liza, I can't pull my agenda up here.
Yes, we are now on to the administrative rule update.
Okay.
Thank
And
you.
is Amanda ready for that?
I am ready. Good morning. For anybody who is new here, what I do here is I'm from the Office of General Counsel, and I just pop on these meetings to update you guys on Medicaid rules that are currently in the promulgation process. So I have 2 rules that I'll go over with you today pretty quickly. The first one we call our co-payments rule, and I'll give you the LSA number, which is 25-479. The purpose of that number is you can go onto the Indiana Register, which is through IGA's website, and type that number in and get some more information about the rules. So again, that one's 25-479. And for this rule, it's going to amend rules at 405 IAC 1 and 405 IAC 5 concerning co-payments for certain Medicaid programs. And this rule change is a result of House Enrolled Act 1513 from 2023. So we are just bringing our rule into alignment with what the legislature already did in Indiana code. So it's not making any changes that haven't already been made. We posted a notice of the rule and of the public comment period on October 22nd, and now I will have a public hearing on the rule on November 24th. If nobody has questions about that rule, the next one that I have is the professional dispensing fee. That one is LSA number 25-436.
This is Representative Shackelford. What exactly are the changes in the rule? What exactly is the rule?
So for the co-payments rule, it's removing co-payments for all Medicaid programs with the exception of HIP, CHIP, and MedWorks.
Okay, thank you.
You're welcome. For the second rule, the professional dispensing fee rule, again, 25-436. And this proposed rule is going to amend 405 IAC 5-24-6 concerning the professional dispensing fee. We had a public hearing on this rule just last week on October 27th, and we did receive some public comments. So we are currently reviewing those. They will have to have a second public comment period. So those comments are currently being summarized and responded to, and then those summaries and responses will be posted when we post notice of the second public comment period. Does anybody have questions about that one?
And what exactly does the rule say for the dispensing fee?
So this one is lowering the professional dispensing fee as a result of a survey that was conducted to make sure it aligns with what the actual costs are.
Do you know what it's lowering it to?
Off the top of my head, I don't. It's from like 10 something to
Amanda.
9 something.
Yeah, this is Kat. I can help with that. It's lowering it from $10.48 to $9.63.
$9.63.
And that applies only to the fee-for-service prescriptions.
Okay, only to fee for service. So outside of fee for service is going to stay 1048.
No, it's much lower in the managed care. The managed care entities negotiate a much lower rate.
Okay, all right, thanks.
All right, thank you.
Kat, I'm sorry, Amanda, is that it?
That is it. Thank you.
All right. I neglected to indicate that we have the minutes of the June 2025 meeting have been sent. Since many members are new, I'm not going to ask that we vote on those, but just that we make them public and acknowledge that they exist. The next meeting is currently scheduled for January 9th. Is that accurate?
Yes, that's accurate.
Okay. And we will do that at Representative Shackelford's comment in person, and we will also intend to have a virtual option for those who live in places that is more time consuming to get to Indianapolis, or if we have a snowstorm. All right.
And Secretary Robe, if I can, just real quick, this is Liza. Just wanted to apologize for the technology difficulties as we transition to this new format. I do know that Representative Clear has joined with us. We're having some audio and mic issues, but I did just want to acknowledge that he has been with us this morning. Thank you.
And do we have a time on that January 9th meeting?
Liza, do we have that calendared yet? Maybe Lindsay knows.
We will have the calendar invite sent out to MAC members shortly.
Okay, thank you.
Okay, one last chance for questions if you have them.
Can I ask a clarifying question? This is
Yes.
Sarah Boslet. I'm a pediatrician. I was wondering, you had mentioned the FQHC expenses and that there was a variability of $200 to $600 per visit. Can
Yes.
you elaborate on that a little bit? What causes that variability?
I'm gonna, I'll try to say this as politely as I possibly can. Entrepreneurial FQACs have figured out ways to increase their PPS rate. And those are generally, the process for governing those rates is a federal process. So we've got to get our hands around that. It's really hard to imagine that kind of differential exists. And is that we have some FQACs that are being paid 3 times as much as other FQACs for providing what is ostensibly the same service.
And just so I understand, is that mostly then the payment coming from the federal government, or is Indiana also paying more because of those rates?
No, so it depends on so there are so Medicaid has, when I was here the last time, Medicaid was relatively simple. Every dollar we got from the federal government was matched at the same rate. That is no longer the case. So there are some programs that are matched with 66-33 or 65-35. There are other programs that are 75 federal, 25 state, and there are other programs that are 90 federal, and 100% and 10% state. So depending on the patient mix and the reason and the kind of program that they're on, they get a different rate. So yeah, the answer is yes, it costs the state of Indiana money. The general overall blend rate in that population would be about a 70-30 blend rate. That's the 10,000 foot view of this.
Okay, thank you.
Okay, any other questions? All right, if you have comments, you are welcome to send them to the inbox that we have, or ask the secretary. And I will thank you very much for participating today. And I would entertain a motion for adjournment.
Motion to adjourn.
Do I hear a second?
Second.
Moved and seconded that we adjourn. All in favor, please say aye.
Aye.
Okay. All right. The ayes have it, and we will look forward to seeing you on the 9th, if not before. Thanks again for your participation.
Thank you.